The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. I want to welcome you to this morning's webinar. My name is Joe. I'm the training manager here with PrognoCIS. We're going to go ahead and get started on today's presentation. Before I do, in case you're not familiar with the way these webinars work, if you'll notice on the diagram here, you've entered the webinar today in auto mute mode, so you're not able to speak directly to me. However, at the end for questions and answers, you will have the opportunity of clicking this icon to raise your hand. That will allow me to unmute you. You also could type your questions into the question box if you so desire. So at the end of the session, which is going to be right around an hour, if you do have questions, I'll certainly be able to answer them for you. Today's session is with regards to meaningful use and capturing the data in PrognoCIS, specifically for the measures of stage 3. There's multiple webinars have been going on for the last couple of months with regards to meaningful use, quality payment program, etc. We're not going to get into the details of the program today. However, if you are attending, I'm assuming that means you have already been attesting at least 1 or more years under meaningful use as a Medicaid eligible provider. Because as of December 2016, meaningful use no longer is available for Medicare providers. It is for Medicaid providers only. And the deadline for registration for any new participants was also December 2016. So therefore, we're not going through any of the eligibility, participation requirements. This is just the homepage at CMS as a means of a reminder. But if you notice there at the bottom, it does mention that 2016 was the last year. The program itself, however, does continue through 2021 as far as being able to do the attestation. This is also applicable only for Medicaid Medicaid eligible providers. Because of the cutoff at 2016, if you are one of those providers that do both Medicare and Medicaid, you do now have the ability of participating both under Quality Payment Program MIPS as a Medicare provider, as well as meaningful use as a Medicaid provider. And that's what some of the other webinars we've been teaching are with regards to. But specifically today, we're looking at stage 3 meaningful use core objectives and how those are captured within PrognoCIS so that there's no guesswork as to your documentation on an encounter level. First of all, you do have to make sure that you have assigned yourself under the meaningful use settings master for stage 3. This also, again, is covered in a separate session, but just as a means of a reminder, whether you are also doing the MIPS as a Medicare provider and or meaningful use stage 3, as you see the number 2 bubble here, you do need to choose stage 3 for each provider in the practice. And that is under your settings configuration menu. When you do that, then as you see the number 3 bubble at the very bottom of this setup, there is a meaningful use tab. All of the core objectives that we're about to look at will be pre-selected by default, but then any of the additional optional measures will be available for you to also select if those are applicable in your practice. So starting with the first core objective, which is to protect your patient's electronic personal health information. There's a security risk analysis measure. Now, this does not require data capture in PrognoCIS, so there's no percentage of data capturing in a numerator-denominator structure. You'll notice in the upper right in the green triangle, this says that you will be attesting as to a yes-no value. In doing so, in order to attest yes, then you do have to maintain locally within your practice, outside of EHR, your documentation to support all of the different risk analysis processes you followed. Now, if you've been doing meaningful use for multiple years, you probably already have all of this established. But if 2016 was your first year and this is going to be your second year and you're not yet familiar with that, we do have a user guide that you can download from our resource center that steps you through all of the different things that are looked for in an audit as far as what you need to maintain. But again, this is something outside of EHR, so there's no data capturing. The attestation would be to the affirmative, and if you got audited, you just need to be able to substantiate that with your internal records, your policy manual, things like that. Now, starting with core objective number 2, you will notice now in the triangle in the upper right, there is a percentage. When you see that present here on the slides, that is the numerator requirement or the threshold for compliance of that measure. So basically, with regards to your meaningful use measures, the way your compliance is tracked by CMS is based on these thresholds that they've defined. So putting it into the terms of a mathematical equation, you're going to have a denominator which represents the patients or encounters or prescriptions, as in this case, that potentially qualify for that measure. And then the numerator is how many within that subset you actually are compliant with. And the difference there, or the percentage of that calculation, is what you need to exceed in order to be given full credit for the measure. And that percentage will be different throughout all the different measures. So in the context here of the electronic prescription measure, the denominator is going to be looking at all permissible prescriptions written inside the electronic medical record ordering system. The only way you can be excluded from this measure is if you write less than 100 prescriptions during your reporting period, or if there is no ERX-enabled pharmacy either within the walls of your practice or within the 10-mile radius of your clinic. So most of you, if you do write prescriptions, are probably in a situation where there is an ERX-enabled clinic, so most of you probably will not be able to exempt this measure. Now, the other piece here, if you notice in the blue box at the bottom, that term permissible prescription, by default, it is going to be every medication, controlled substances and non-controlled substances. Within the EHR, however, in order to electronically prescribe controlled substances, you must have implemented the ePCS module. That requires that the physician go through an identity proofing at the federal level, procure a security token, get set up for your ID and password, and then when you do the electronic prescription of a controlled substance, you have to have access to that token. If you have not done that, and you don't want to be penalized for the controlled substance prescriptions in this measure count, you need to make sure that in that settings master, you have taken the exclusion for ePCS. If you do ePCS, all of the prescriptions will be counted then. But if you don't do ePCS and you forget to take that exclusion under the master file, those prescriptions will be counted in your denominator, but of course they would not be counted in the numerator because you would not be able to e-prescribe them. Now, with regards to the way the data gets calculated or captured on your prescription screen, and this is whether it is a new prescription or a refill, because basically the medication screen is the same. It just looks a little different when you're doing it as a refill. But the criteria is, first of all, this is a two-part measure. The way CMS has defined this objective is that, one, you must query the prescription for drug formulary, and then two, you must submit it electronically. So the way this is incorporated within PrognoCIS, the first part, which is querying for the drug formulary, this is actually automatic. As soon as you have arrived your patient at the front desk, the query is sent out to the SureScript Pharmacy Benefit Manager to query what that patient's pharmacy coverage is. And it is stored here under the formulary status. You see the number 1 on my slide, and it would tell you there if they're on a formulary, tier 1, tier 2, etc., if there's a copay, and then if the coverage is there, if you click the little ellipsis icon next to my number 2 bubble, that would open up the formulary details, so that if you then decided that you wanted to prescribe a formulary drug as an alternative, you could. Now, that is not the requirement of the measure. You don't have to actually read the formulary. You don't have to prescribe the formulary. The measure simply says that your EHR must give you the ability to query a patient's formulary. And that is automatic. When you become a e-prescribing provider in PrognoCIS, this feature is automatically enabled. So all of your prescriptions will automatically be compliant with this piece of the objective. Now, the second part is that you actually transmit it electronically to the pharmacy. This requires, one, that the pharmacy be an ERX-enabled pharmacy. And if you notice the part here in my turquoise circle underneath the number 1 bubble, within PrognoCIS, when you choose a pharmacy, there is a label to the left of it in red. ERX indicates they take non-controlled substances electronically. EPCS means that they also take controlled substances electronically. So you may see ERX without the EPCS or with, as you do in this example. If you do not see ERX at all in red and that label area is blank, that means the pharmacy does not accept e-prescriptions. The drug would still be in your denominator. It would not be in your numerator, however, because even though you put a pharmacy on there, if it does not take ERX, you cannot transmit it electronically. So that is one of the criteria for the numerator to be captured, is it must be an ERX-enabled pharmacy. The second piece is down in the drug detail section. If you notice, there is a type column for each drug. The not signed is an example of an EPCS, a controlled substance, where the provider does participate in that, but has not yet securely signed this controlled substance with his security token. If you're going to do EPCS, that needs to say signed instead of not signed, which means you have entered your security token and password to secure it. The second drug here, where the type is ERX, is your non-controlled substance. So the type has to indicate it is either an ERX or a signed controlled substance, and then the pharmacy label has to support the same type. Then you click the ERX icon, which transmits it to SureScript. That is when it would get counted into your numerator. So for the electronic prescription core objective, 60% of your prescriptions that you write need to qualify for drug formulary, which will be automatic, and then you need to transmit it to an appropriate pharmacy. Now, the next core objective is clinical decision support interventions. This actually has 2 components as well, and both of these components are a yes-no attestation. So again, this means that there's no data capture in PrognoCIS. However, these are functionality within the system that needs to be enabled, and you need to be using those functions. So the denominator, numerator, again, you're just going to attest yes. But with regards to compliance, since there's 2 sections here, for the first part we're looking at is what we call in PrognoCIS an expression. You need to have at least 5 of these expressions enabled throughout the reporting period, 4 of which need to be closely tied to your electronic clinical quality measures. If there are not 4 relevant clinical quality measures for your specialty, then these expressions need to have a high priority significance to your specialty as far as the health conditions you treat. So you need to have 5 expressions defined relevant to your specialty and the health conditions you treat. Now, this is done under the expression master as far as building them. As far as the way they work in the system, this is an example of one. An expression is basically just a pop-up. When they're defined under the configuration level, you dictate the text that displays in this pop-up. You also dictate what triggers it. It can be triggered off of anything at the clinical level. It can be triggered from a vital sign, from a chief complaint, from a pain score, the result of a lab test, a diagnosis, whatever's relevant in your world where you need to have some clinical significance informing you or your staff as to how you need to intervene with that patient, what you need to do to treat that patient successfully. That is what this particular measure is saying. So you would get the pop-up wherever you triggered it. Now, the way you define it is under the configuration master, and that is the screen you're looking at here. When you go into your workflow expressions master, you would, of course, give it a name. You would trigger it. There, the number 3 bubble is where you define the triggers, whether it's going to be on the assessment, the HPI, the vitals, etc. If it's under a specific complaint, then you can pull those complaints in. The number 4 bubble is where you enter your text that the user will see in that pop-up, and that is simply free text. Now, it's important to note here, as that big blue bubble is telling you, by default, your PrognoCIS library has clinical quality measure specific expressions preloaded. So to be quite frank, most of you are probably 100% compliant on this measure without doing anything. With the exception of, again, if those clinical quality measures are not relevant in your specialty and you were to be audited, then there could be a red flag there. So you do want to make sure that the ones that are preloaded in your system are significant with your patient population, or you would need to create your own. And then that bottom part of the screen is where you define all of the conditions you want. And that, again, is like building the mathematical equation. You're putting in all of the conditions you want, age parameters, diagnosis criteria, etc. All of that is what would trigger the pop-up that your user sees. So 5 of those of relevance in your specialty, as long as they're enabled, and again, for compliance, you just need them enabled in order to attest yes. You do not necessarily need to ever see the pop-up, because these pop-ups, again, are very specific to conditions. And if those conditions are never satisfied or not applicable, then you're not going to see the pop-up. So seeing the pop-up is not significant in being compliant. Having the expressions exist is what is relevant. Now, the second part of this measure is drug-drug, drug-allergy interaction checking. So very similarly, these are clinical decision support messages. These are automatically popping up in the system. Does not require you to take action, does not require that you even see them. The functionality for compliance, however, is that your EHR needs to give you this kind of interaction so that when you prescribe a drug and you have documented allergies, the system warns you that the patient could have an interaction. Now, this also is an automated feature, so by turning on PrognoCIS, you automatically have this functionality. There's nothing you need to do as far as being able to attest yes. But just so that you're aware, it is a pop-up similar to this one. Depending on the severity level of the interaction, you're going to have the opportunities in the bottom to ignore it, to overwrite it, to fix it, to go change the drug, etc. But again, it doesn't matter whether you take an action or not. You'll be compliant just by the fact that this functionality is turned on in your database. And these are the properties that control the checking. Just FYI, because even though they will be turned on by default for you, you do have the ability of playing with the severity level if you want. Maybe you only want to see the alerts in the real critical severe cases. If it's just going to cause like a minor nausea or rash, you don't care about it, then you can set your severity level accordingly. That is not, again, part of the equation. That's just part of the functionality. The fourth core objective under stage 3 is medication orders. Now, this is not the same as e-prescription that we just saw up above in measure 2. That was specific to prescriptions going electronically only. This is now looking at medication orders across the system, whether it's electronic or not. So it is looking at a little different subset because now the denominator is going to be all medications ordered regardless of if you do controlled substance or not. So that exclusion of EPCS that we spoke of earlier is with regards to measure 2 only. Whether you do controlled substances electronically or not doesn't affect measure 4, because measure 4 is all medications ordered, period, not how you transmit it. They just want to make sure that the medication you prescribe is in the electronic medical record, not how it gets to the pharmacy. So this again is looking at all new prescriptions as well as refills. 60% of these need to be in the EHR. The only way to exempt this measure would be, again, as we saw up above, if you write less than 100 prescriptions. So this, again, is looking at the prescription screen, but is only looking, did you save the prescription in the EHR? It doesn't care if it's ERX or if you printed it to paper. You don't even need to choose a pharmacy, because when you're printing a prescription, you don't need a pharmacy at all. That's only required for the e-prescribing. So as long as you enter your drug details on the prescription screen, you're counted compliant in this measure. And then you can print it, fax it, e-prescribe it, whatever you want with the prescription. Now, the second part of Measure 4 is similarly looking at your orders, but specifically lab. So this core objective 4 actually has 3 pieces to it. It's looking at your computerized provider order entry, prescriptions, as we just saw, now lab, and then next we're going to look at radiology. So it's a single core objective as far as meaningful use data reporting, but there's 3 components to it: prescription, lab, radiology. All of them require that you're doing the order in PrognoCIS for the patient. So now in the context of lab, it is also a 60% requirement. The only way you can exempt is if you write less than 100 lab orders. So if you don't do lab work less than 100, then you can exempt this measure when you do your reporting. It is applicable to all labs that you order internally or externally. So whether you're testing it in-house or you're sending the patient the specimen to LabCorp or Quest or wherever, it counts if you are the one prescribing the lab test be ordered. So this is now looking at your order sheet in PrognoCIS or the lab order screen, depending on if you use the order sheet mechanism or not. It's the same functionality in the EHR, it's just a different screen. But the status of the lab test has to be either approved or ordered in order to be counted as a electronically ordered laboratory test. Doesn't matter how you get it to the laboratory itself, whether you're printing a paper requisition, e-faxing it, e-sending it, whatever, as long as you're entering the lab test order in EMR, you're covered. And the same is true for your x-rays or any radiological exam, anything beyond lab. So 60% again of these need to be in the EHR, whether you're sending it outside or doing it in-house. And again, this matters whether you're using the order sheet or the radiology order menu option direct, as long as the status equals approved or ordered, regardless of who the vendor is. So core objective 4, you have 3 components: prescription, lab, radiology. You need to make sure that you're doing the order in PrognoCIS as far as documenting it's something you're ordering. Getting the requisition to the pharmacy or to the lab vendor doesn't matter if it's electronic or paper, fax or phone call. As long as the order is documented on your EHR for more than 60%, you're going to be compliant. Excuse me. Core Objective 5 is providing electronic access to your patient's PHI. This is an 80% requirement. The denominator is looking at all unique patients seen. So whereas up above we were looking at orders, prescriptions, this is now looking at patients that you treat. Not number of encounters, but within your reporting period, if you see the patient at least once, they're counted in your denominator. And then regardless of how many encounters they have, at least 80% of those patients treated at least one time need to have access to view, download, or transmit their PHI. That, of course, uses the patient portal. Now, the only way you can exempt yourself from this measure is if your practice is in a jurisdiction geographically where more than 50% of your households do not have broadband availability, or if you do not have office visits, where you do not bill patients as an office visit. Those are the only way you can exempt this measure. Now, giving the access to your patients does not mean they have to use it. That's another measure that we'll look at. This specific measure that requires 80% is simply you give your patients the access to the portal, and then it's up to the patients whether they use it or not. So the portal, you give a user ID and password from underneath patient register. So the screen you're seeing here is the patient demographic screen where your front desk registers your patients. They have that icon there above the patient's photograph where they can assign a user ID and password. As long as that icon is showing up as red, that means that a user ID and password has been issued. Now, when you capture an email address for the patient, the system automatically emails them a user ID and password, so it's automated and you don't have to do anything manually as a human. other than enter the email address. That is not a mandatory requirement, however. So if there is no email address, then your user has to manually go in here and add a user ID and password. Either way, you'll be deemed compliant if that user ID exists. Now, with the new version of PrognoCIS and with Meaningful Use Stage 3, they have now required us to also give an external option. So that is what we're calling the ePHI. This is an application program interface that is not the same as the patient portal. So this is a new option, brand new to this version of PrognoCIS, that you can use instead of the portal or along with the portal. This scenario is a different URL. So the patient would need to know what that URL is, of course, and then they create their own password. So instead of you or your staff inside PrognoCIS giving them a user ID and password, since the requirement is that this be external to PrognoCIS, the patient would need to create their own login by doing a sign up. Either option will give you compliance for this measure. It's just a matter of this is inside PrognoCIS where you are giving the ID and password to your patient under patient register, and that is accessing the patient portal, or the external ePHI, which is a new external option where patients can do a self-sign-up. That does not register the patient in PrognoCIS. That is not the portal. It is a completely separate, new, independent functionality. In both of those cases, however, whether you're using the portal or the ePHI, the health summary is what the requirement is that the patient be able to view. And they need to have this access within 48 hours. So the logic in PrognoCIS now is this health summary is automatically available in real time for your patients. It's accumulating as you build your encounter. So once that encounter gets started, even though I'm showing you the encounter close screen here, as soon as that encounter is marked arrived, this health summary is automatically available for your patient to look at. The requirement is that you have 48 hours to make it available. Now, it's going to accumulate in real time as you're documenting. So throughout the course of your patient's visit, that detail, of course, is going to change. Now, physically, of course, if the patient's in your office getting treated, he's probably not logged into the portal. So he's not going to see it change in real time. But just so that you're aware how the functionality is, if you don't want the patient to see it until you have quote unquote blessed it and you've finished your note and you've locked the encounter, then you can come in here and deselect these checkboxes, and it will not be available for the patient to look at until you go in and reselect the checkbox when you close the encounter. The default behavior is these options will be selected, meaning the patient can always see it. But since the requirement for compliance is within 48 hours, you do have the option of deselecting these options and then reselecting them if that is your choice. The selection, the check mark in these options in conjunction with the ID and password, whether you've done it internally through register or the patient has done sign up, the combination of all of that is what gives you your compliance. Because the measure says patients need to have access to their information within 48 hours. So all of that is giving them the access. Measure 5, electronic patient education. This is actually the same measure we were just looking at, but it's the second component of it. This is specifically now with the education being available electronically. Numerator here is 35% of the unique patients seen are given their education, which is clinically relevant according to the EHR, and they're given that education electronically. So it doesn't count if you're counseling your patient face-to-face, which most of you are doing during a visit anyway. This is when you are physically giving them education information electronically. The only way to exempt this would be, again, if you're in an area where there's no broadband availability, because the assumption here is that the patients are going to view this electronically either through an email or through the patient portal. Now, please note that within PrognoCIS, as of stage 3, only the Medline Plus education is being counted in the numerator of this measure. So if you have been a client for many years, and before we had the Medline Plus electronic education embedded, we only had PrognoCIS education. PrognoCIS education still exists, but that is what you control. You have a master file under configuration where you define the contents. That is not counted in this measure. In previous years, that was also acceptable in this measure for education. As of stage 3, however, it is only counting the Medline Plus electronic education. And that is applicable throughout the system wherever you see the little blue book icon in the EDU column for education. You see that on your face sheet, whether past medical history, current medication, or allergy. You also see it on your assessment, and you see it under your lab results. So in all 5 of those locations, if you execute one or more pieces of this education, when you click the icon, you'll notice here at the bottom of my slide, your options are 1, activate it to the portal, or 2, email it to the patient. And then the patient will get the web link to open up and view the education material. So 35% of the patients you treat, you need to do that for. In previous years, that measure only required 10%. So they have now increased it to 35%. And it must be electronic now. Core Objective 6. This also is a multiple measure. There's 3 components here. So the first part here is your coordination of care, patient engagement. This is where the patients actually do something now on the portal. So patient engagement means that the patients do need to take action now. Now it's low, it's only 5%, because obviously you can't control the actions of your patients. But at least 5% of them need to be able to activate, go onto the portal, look at their health information, either look at it, download it, or transmit it. So this VDT means view, download, transmit. Their PHI. So up above, we talked about the health summary information being available. That was one measure, that you make the information available. Now, not only is it available, but the patient needs to take action with it. So when they log into the portal, on the left-hand side of their menu, based on however you've configured it in your practice, they will have the health summary as well as past health summary. The health summary is always the most recent, whether they are actively being treated or they were here last week and they haven't come back in since. This is the most recent or current information. The past health summary then is date-driven. Either one, you have these options at the bottom to print it, to download it, to transmit it. The downloading it would be to save a copy on their local computer, or if they wanted to put it on a thumb drive or something. Transmit it allows them to electronically email that information to a third party. If they go to the past health summary, it has those same buttons at the bottom as far as downloading and transmitting, but the view option is up above because it's specific to the date of service. So if you're going to look at it, you have to click the view hyperlink for the specific date of service because you can only look at one at a time. But down at the bottom where you can download transmit, you can actually select multiple ones up above by clicking the little checkbox next to the dates of service. So you can download and transmit multiple or view singularly. Any of those combinations, at least 5% of your patients need to do it, whether they just come in here and look at it or they download transmit. The second part of this core objective for patient engagement is secure messaging. Now, this also is a 5% requirement where you are having a secure message interchange with your patient. So this means that you can send a message to your patient. The patient can submit a message to you, which you can then either at least read or reply to. The patient can submit a form from the portal. Maybe you have your patients filling out their new patient history forms and stuff, or questionnaires. Laboratory radiology results that get posted to the portal once you've reviewed it. Those also count. So for any of you using the portal, since all of these measures we're talking about are mandatory, you honestly are probably going to be 100% compliant here because it's only a 5% threshold. And because your lab and radiology, unless you don't do those, the way it's written, those results become immediately available once you've marked it as reviewed. And therefore, a secured message is sent to the patient telling them the results are available. Also, for those of you that use the patient portal forms, as soon as a patient submits a form to you, that's counted. So this is a very easy measure for all of you to be compliant with. But it's looking at activity from the portal executed under the patient's login to the EMR, or a message from you as the eligible reporting doctor to the portal. That is what constitutes secure message. And then the third piece of this measure, very similar, this is just integrating patient-generated health data. So again, we're going back to the patient forms, or of course, we also now allow patients to send you attachments through the portal. So this again requires the patient to do it, but if you've got the portal in place, then you probably have your patients filling out some sort of paperwork anyway, or let them know that they have the ability of sending you images, documents. 5% of these also needs to occur. So core objective 6 is patient engagement. So secure messaging, generated health data. The patients need to be using the portal, basically. Now, core objective 7, we have 2 components here. This is now dealing with referrals. The first part here is referrals out. So this is when you are transitioning a patient to some other care provider, referring them to a specialist, referring them out for a test or a procedure or whatever. Where you are doing a transition of care / referral, it has to be electronic and it has to have the patient CCD electronically attached. This is done through our letters out module. The only way you can exempt yourself is, as most of these electronic measures, if you're in a jurisdiction where 50% of the households do not have broadband access. So in this piece of the measure, it's letters out. And in order to be compliant, you would need to identify your letter out as a transition of care. So you see the little checkbox there at the top with my number 1. That will put this in the denominator. That says this is a referral out. Then at the bottom, or in the middle here where you notice the number 2, you're going to choose your template, your referral letter. Along with that, you're going to attach, by clicking the attach button, the CCD, Continuity of Care Document. That is the CMS dictated electronic clinical record, the PHI. It's in a format called CCD where CMS has dictated the content. The system automatically compiles that documentation. So this is not a template you create. The system compiles it based on all of your clinical documentation. You're just attaching it here by going into the attach button. And then once you save that TOC letter out with the CCD attached, that gets it in your numerator. And then you're going to send it electronically through secured mail. This does require a secure electronic messaging. That is through the SureScript end-to-end network. This is not just emailing it to somebody's Yahoo. That is not secured. So if you're going to refer this patient to a cardiologist or to a radiology center, an acupuncturist, whatever the referral is, the recipient has to have a secured email through an end-to-end network. 90% of the country is using SureScript as the clearinghouse for their secured messaging, including us. There are other clearinghouses out there, however, but it does need to be an electronically secured dual domain email address to where you're sending the information. And then even though here in the PrognoCIS screen it looks like you're just emailing it, You'll notice my 7A bubble, email type needs to be secured, and then the email address next to my 7B, it's a dual domain. So you see myclinician.secure.com is going to be something.something.com. So that's the first part of this measure. The transition of care out must be electronic, must have the CCD attached for 50% of the patients you're referring. Now, the second piece of this is receiving a referral in a transition of care where somebody has sent the patient to you, and you're incorporating that electronic data into your PrognoCIS EHR. This is a 40% requirement. So this is now going to be requiring that you have a secured messaging and you're getting this CCD electronically from another provider who has sent it to you through a secured mail in advance of the patient's arrival to PrognoCIS. So when you get this CCD from the other provider, it's going to come into your PrognoCIS inbox. You see there my number 1. The subject line is going to tell you it's a clinical message, and it's a CCD, a continuity of care document, which basically, again, is that electronic PHI that this other person is sending you. When you click the little zoom icon, you'll notice here in the email message, it shows as an attachment. Now, the way it works in PrognoCIS is if you do not have this patient arrived yet, as long as they do not have an open encounter, this documentation will automatically be attached when you arrive the patient for their next appointment. So let's say you have a patient that you're treating today on Wednesday, November 15th, that was referred to you last week from a doctor across town. Well, the doctor across town last week sent you this message with your patient's CCD attached, your patient's on today's schedule. Right now, if that patient's in a scheduled status, you don't see this information on his chart. But as soon as your patient is marked arrived at the front desk, this information gets attached. That is how you're getting numerator credit on this scenario. So 40% of the referrals that you're getting, the sending party who's referring them to you needs to be sending you their CCD. Core Objective 7 is Clinical Information Reconciliation. There's also 3 parts here because we're talking about reconciling medications, reconciling allergies, reconciling problems. This is for 80% of your new patients. You need to perform clinical reconciliation. So this is on your face sheet. You got 3 squares that is applicable here: the current medication, the allergy, and the past medical. I'm only showing you here for the sake of today's discussion the current medication, if you look at the bottom of the screen. But all 3 of these cells on your face sheet has this transition of care section when you actually go in to document meds, allergies, or problems. So the transition of care is where that information is coming in, the CCD that we just talked about. When this patient's marked arrived and that CCD has come in, it automatically gets added here to your face sheet under this transition of care section. And you're reconciling by verifying with your patient and then adding it up above to your PrognoCIS data. So when you go into these 3 pieces of your face sheet, the transition of care section is where you're entering the new data, whether you're entering it manually. Let's say it's a brand new patient, they weren't referred to you, you still have to do a transition of care under this objective. So whether it's a referral and or a new patient to your practice, you are going to enter the new information here under transition of care and reconciling it to your PrognoCIS chart by adding it up above. 80% of your new patients and referrals. Now, the last core objectives is your public health reporting. There's actually 5 options under public health reporting. 2 of these are not applicable in 2017. So out of these 3 that are available in 2017, you must attest to at least 2 of them. So we have Immunization Registry, Syndromic Surveillance, Electronic Case, which is not applicable, Public Health Registry, or Clinical Data Registry, again, not applicable. So out of the 3 that are applicable in 2017, Immunization, Syndromic, Public Health, you need to choose 2 of those. For immunization, and these incidentally are yes-no attestations. So it's not a matter of data capture where an X number of patients need to have certain information. It's just yes or no, do you do it? Yes or no, do you have this registry interface turned on? So immunizations, for instance, if you don't do immunizations, maybe you're an eye doctor, pain management, OB doctor, you don't do immunizations, you can take the exemption for this measure. So it would still count as one of your 2 objectives. But instead of saying, yes, I do it, you'd be saying, yes, I qualify for the exclusion. If you have the registry, however, because you do vaccines, the requirement under stage 3 is that it be bidirectional. Previous years, unidirectional was sufficient, meaning when you administered a vaccine in PrognoCIS, you transmitted the data to the registry. Well, now with stage 3, it requires that you also have the ability of querying a patient's vaccine history at the registry and importing it to PrognoCIS. So it is now a dual interface, exporting to the registry, importing from the registry, for those of you who do actually do immunizations. Syndromic surveillance reporting. It is now applicable in 2017 for urgent care only. So if your specialty is other than urgent care, you will take the exclusion here. So these measures are very easy to get credit for when you do attestation, because if it's applicable to you, you're going to have the interface in place, so you'll attest yes. If it's not applicable to you, you're going to take the exclusion. Number 3 is not applicable in 2017 for anybody. Now, Public Health Registry, this is also an option, one of the 3, since you have to choose 2 of them. This is for 2017 through the National Healthcare Survey. Basically, this is a mechanism from DHCS, which is part of the Centers for Disease Control. Since you are a professional doctor, not a hospital, you would choose the National Ambulatory Medical Care Survey. Basically, this is another format of a CCD. The registration is simple and free. You have the website there at the bottom where you can register, and some of you will randomly be chosen to submit test data for an X number of days. It may be 1 day, it may be 1 week, but unlike most of the measures up above where it's for a 90-day period, this is just going to be random if required at all. And then CDR is not available yet in 27, or is not applicable for PrognoCIS users because PrognoCIS is not a clinical data registry, and we are going to be reporting the data for you when it comes time to attest. So basically, those are your core objectives under meaningful use stage 3, and whether or not data is required in PrognoCIS and how the data will be captured into your numerator, demonstrating compliance. Now, we're not going to get into it here with regards to the appendix, but there are reports available. Attestation starts, of course, come January 1, once the reporting year is over. When that happens, we will be having more webinars on reporting, on attestation. But in the meantime, if you want to spot check yourself, there are 2017 meaningful use reports available for you to generate. And then just winding things down, if you need any assistance, if you want further hand-holding or help setting up your stuff, go to the Resource Center and add a ticket. There is a subject there called MU/QPP. That will submit a case to the technical support team, and then they can get somebody in touch with you. All right, so that completes the session for this morning. Are there any questions under the Meaningful Use Stage 3 umbrella? If so, you can click that little hand icon so that I can unmute you, or you can actually type your question to me. All right, I don't see any hands going up, so I want to thank you for your attendance today, and thank you. Y'all have a good week. Bye-bye.